You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 17th, 2023. This week, AFib, stroke, bradyarrhythmias, thrombolysis in stroke, nurse practitioner versus MD care, and the most biased paper of the year, and it's in the left atrial appendage occlusion space. The first paper and topic highlights one of the most important challenges of the modern age of medicine. That is, this loosening connection between the diagnosis of a condition and our ability to improve outcomes. And I don't want to exactly call it overdiagnosis. It's not exactly that. It's more an issue with our technology redefining disease and perhaps redefining normality. Before I launch into a super important paper in the AFib space, I want to point you to a tweet from Dr. Ade Adamson, an academic dermatologist at the University of Texas. He tweeted out a picture he published in the New England Journal of Medicine in 2021, and it is a graph showing two lines. One was a steep rise in the diagnosis of cutaneous melanoma over the 40 years. Big, steep, high slope line. And the other line was a flat line, totally flat at the bottom, showing absolutely no change in mortality from melanoma. And of course, I'll put a link to that tweet. A remarkable post hoc analysis of the LOOP trial details a similar type phenomenon in cardiology. First, I want to say that many times post hoc analyses are data dredging exercises that are aimed at marketing, not science, but not this one. First author, Soren Didrikson, a young MD PhD from Copenhagen, along with other co-authors of the LOOP trial, were interested in the prevalence and prognosis of bradyarrhythmias in patients implanted with a loop recorder in the LOOP trial. Now, slow the treadmill or bike speed down, everybody, because this paper is going to teach us many important lessons. First, a very brief review of the LOOP trial. This is one of the seminal trials in cardiology this decade. It was published in Lancet in 2021. The trialists randomized more than 6,200 patients without AFib, but with high stroke risk features to screening with an ILR, implantable loop recorder, or screening with usual Danish medical care. And after more than 5 years, they found 3 times more AFib in the ILR group. That led to nearly 3 times more use of oral anticoagulation, right? So this is going to be a good result for the loop recorder and screening. Yet the main result was a 20% reduction in stroke that did not meet statistical significance, and a 26% increase in major bleeding in the ILR arm that also did not reach statistical significance. In other words, LOOP was a clearly non-significant trial because even if you believe the 20% reduction in stroke was signal, not noise, it was countered by an even greater increase in major bleeding. Screening for AFib with the best modality for screening, the always-on implantable loop recorder, failed to change outcomes, despite the 3 times increase in diagnosis. You see the pattern, right? It's just like the melanoma picture of Dr. Adamson. Okay, now to the important post hoc study. The authors of LOOP and anyone who uses ILR devices know that you may implant them looking for AFib, but they are also going to find other things, scary things, like sinus pauses or heart block. Now, surely the idea is that it's good to know, delve into the findings of this post hoc study. The primary endpoint of the study was bradycardia episodes, pacemaker implants, syncope, and sudden death. And they defined bradycardia episodes by either having sinus node dysfunction, and this was defined as an inadequate heart rate compared with physiologic need, and that could be due to sinus bradycardia, pauses, exit block, or just simply chronotropic incompetence. The second way they defined bradyarrhythmia was low-grade AV block, like first or second degree AV block with a P to QRS ratio of 2-to-1 or lower, or high-degree AV block defined as complete heart block or second-degree heart block with a P to QRS ratio of at least 3-to-1. Now, they excluded asymptomatic sinus bradycardia, pauses, or AV block during sleep of anything less than 3.5 seconds or longer. They also excluded heart rate of less than 30 during sleep. And what they found was that bradyarrhythmias were detected in 4% of the control group versus 21% in the ILR group. So the ILR picked up 6x more bradyarrhythmia. The detected bradycardia was not symptomatic in 80% of the ILR group versus only 24% in the control group, which makes sense because you'd expect the control group makes the diagnosis of bradyarrhythmias because patients are symptomatic, and I'll come back to that. The most common bradycardia found was sinus node dysfunction followed by high-grade AV block. Okay, pacemakers. Pacemakers were put in 4.5% of the loop arm, 2.9% of the control arm. That's a 53% increase in pacemakers, which was highly significant. But here's the key point. There were no differences in syncope nor sudden cardiovascular death. My comments: I cannot emphasize enough how important these observations are. They're important in cardiology, but they're important also in the grand philosophy of modern medicine. First, let's do the cardiology part. This analysis shows that if you do more rhythm monitoring, you pick up things that we once thought were abnormal. I used the past tense there on purpose. The problem was that these norms, what we thought was abnormal, were established in an era where loop recorders and smartwatches were not even thought of yet. So it's clear now that patients and doctors alike have not recalibrated what we call normal. And one of the revelations of this paper is that when you monitor people with high-risk features, you find that bradycardia, as it's historically defined, is common, 6 times more common than those in the routine care arm. Now, this study was done in Denmark, so the rate of pacemakers was only 53% higher in the implantable loop recorder arm. Had the study been done in the US, you could be sure it would have been much higher. I mean, still, to this day, I am referred patients for consideration of pacemakers due to bradycardia found on some monitor without any symptoms. The authors speculate that there may have been over-treatment with pacemakers. That's funny. Maybe their Danishness makes them subtler or kinder than normal. I'd say it differently. Of course there was over-treatment with pacemakers. If you put in oodles more pacemakers and find no difference in syncope or sudden death, then by definition there was over-treatment. But there's much more to say about this paper. The study's primary aim was to assess the value of finding AFib in patients who are most likely to benefit from AFib treatment, and it did not show benefit. But this post-hoc analysis elegantly shows the off-target effects of screening. You pick up other stuff too, like bradycardia. Another example, CT scans for coronary calcium, they populate lung nodule clinics because they pick up lung nodules. And lung nodules lead not only to anxiety about potentially having cancer, but also to downstream shenanigans such as more CT scans, more biopsies, even surgeries. Now, the shenanigans are much, much more likely to benefit the healthcare system than the patients. Okay, now let's move to the philosophical matters that I mentioned. Here, I see a clash of forces of modernity and medicine. Modernity, especially in the U.S. population, is creating diets of mostly processed food, increasing rates of obesity, lower rates of exercise. Modernity is creating a population of metabolically unhealthy people. But modernity has also created amazing technology, such as loop recorders, smartwatches, CT scanners, and even devices that can measure troponins through the skin. These technologies are being used to diagnose more and more conditions that then lead to more and more interventions. It's like a printing press for dollars for anyone in the healthcare industry. You make patients sicker and you have more devices that can treat them. It's like a tsunami of unhealth for patients. Now, I know I kind of sound emotional about this, but gosh, I hate to see what is happening. I love what technology has allowed us to do in caring for the sick. The advancements in, say, ablation technology and mapping and all these things with interventional cardiology have been astounding. But to move to use technology to transform healthy people into patients, the 60-year-old who was cycling every day to work, who now worries about having coronary calcium, the patient with heart failure doing okay on meds, who now is told they need an internal monitor in their pulmonary artery, or perhaps the worst of all, the elderly patient with unsteadiness of gait, who is convinced to have a foreign body placed in the left atrial appendage instead of just taking an anticoagulant. If you are young and you're listening to this podcast, it is not too late. You can rise up and you can tell people that the emperor has no clothes, that this is all sort of nuts. The solution to better health is not necessarily more technology. It is to eat better food and go out and play. If a loop recorder in high-risk patients can't help, how in the world do we think digitally monitoring younger, healthier people will work? Health is not complicated. There is food, exercise, and good luck. Most everything else is incremental, or worse. And the final comment before I move on, I want you all to look at the data sharing agreement of this trial. Dr. Dietrichson et al. State that they will share the raw data upon request. Okay, next topic, thrombolysis in mild stroke. Sue Hughes covered an interesting trial, randomized controlled trial, called Aramis, that was presented at the International Stroke Conference. This was thrombolysis versus dual antiplatelet therapy with clopidogrel loading in patients who had mild, non-disabling stroke. That's an NIH stroke scale of less than 5. And the bottom line is that more patients in the DAPT arm achieved a high-functioning level, modified Rankin scale 0 to 2, than in the alteplase arm. This was a non-inferiority trial, and it easily met non-inferiority. Now, I'm not going to say much more about the details of this because it's not published and we need these details. For instance, the study was done in China, and the definition of non-disabling stroke is certainly debatable and fluid. But I at least want to mention this study because it's going to be a provocative study and it's going to be coming to a journal. And it's provocative because right now many of these patients are getting lytic therapy. It's also similar to a trial called the PRISMS trial. PRISMS was published in JAMA in 2018. First author, Qatari. PRISMS randomized patients with an NIHS score 0 to 5. The mean that were enrolled was 2.3. There were about 300 patients, and there were no differences in the primary outcome of good functional capacity, but there was a 3-fold higher rate of intracranial hemorrhage. The PRISMS trial was terminated early by the sponsor for, quote, financial reasons, so there's going to be wide conference intervals. But there it sits in JAMA. No difference in functional outcome, 3-fold higher rate of harm. So this whole topic is another opportunity to remind everyone that the lytic therapy for stroke practice sits on very shaky evidence. Many trials have been done and only 2 yielded positive results. NINS, which had substantial differences in baseline characteristics that favored the TPA. Last year, neurologist Ravi Garg convincingly showed that these baseline differences were not likely due to the play of chance, but rather randomization errors, and I'll link to that paper. Dr. Garg, who's a neurologist, also showed that in the most representative meta-analysis of the lytic trials by Hack et al. In 2018, he published in the International Journal of Stroke that there was enough missing data to warrant uncertainty regarding the benefits of this therapy. Again, I'll link to that paper. Finally, neither of these 2 positive lytic trials, NINS or ECOS, have withstood reanalysis. NINS due to baseline differences in stroke severity, and ECOS didn't withstand reanalysis due to statistical error when the authors did not account for baseline imbalances. and a doctor named Alper and colleagues. Alper et al. Used that raw data to make these adjustments, and in their reanalysis found no significant differences. And I know, of course, John, the stroke neurologists all disagree with me, and they've published reanalyses of their own that uphold the positive findings. And I'm not saying lytic therapy does not work in some patients, and I may be wrong about these doubts. There may be a good explanation why the majority of lytic trials aren't positive. There may be a good explanation why independent authors who reanalyzed the ECOS and NINS trials did not come to the same positive results as the proponents who wrote the papers. The missing data in the meta-analysis may not matter, nor the randomization errors in NINS. And the mechanical thrombectomy trials are much stronger. Yet the whole stroke center industrial complex turns on the use of lytic therapy, and the data for lytic therapy is shaky. Imagine if there were enough investigators with the courage to redo NINS in the modern era, we might be surprised. And if lytic therapy for stroke was ever overturned, what a massive reversal that would be. A therapy that doctors get sued for not using fast enough could possibly be proven not effective. Now, I'll let you know when this paper comes out, but I also want to warn everybody. If you look deep into this data, as the emergency medicine community has, you cannot unsee it. So you are warned. Okay, third topic today is nurse practitioner versus MD care. A new study with super interesting methods of simulating randomization suggested that I may have been wrong about nurse practitioner versus doctor-led care. In 2020 and again in 2022, I argued that nurse practitioner-led care will not be inferior to doctor-led care. I know that sounds crazy. I'll link to the columns. They generated a ton of love from the nurse practitioner community and serious angst from my doctor colleagues. But this new paper is a working paper in the NBER journal. That's the National Bureau of Economic Research. The authors are not medical doctors. They studied the use of nurse practitioners in an emergency department system in the VA. They found that nurse practitioners increase resource use and achieve worse outcomes compared with doctors. And the differences were substantial. Compared with doctors, nurse practitioner care increased the length of stay by 11%, the cost of emergency department care by 7%, and the 30-day preventable hospitalizations by 20%. Now, the controversy of this paper comes in its design. The authors used an instrumental variable analysis, IV analysis, to achieve quasi-randomization, and here it gets very, very complicated. The idea, as well as the community EP doctor can understand it, is that the authors sort of leverage two factors. One is that nurse practitioners in the VA system can treat independently, and that there is an exogenous variation in the availability of nurse practitioners on duty to instrument for whether a case is treated by a nurse practitioner or a physician. So they had a sample of 1.1 million emergency department visits. Their approach compares patients arriving at the same emergency department and during similar times that differ in the number of nurse practitioners on duty. They show that the number of on-duty physicians declines with the number of on-duty nurse practitioners, and the number of on-duty nurse practitioners strongly predicts whether an arriving patient will be assigned to a nurse practitioner versus a physician. And under the plausible assumption that patients arrive quasi-randomly within cells of emergency department stations and time categories, the instrumental variables design allows them to study the effect of nurse practitioners on patient resource utilization and outcomes. Of course, the big assumptions were that the arrival of patients are random and there's no other exogenous factors affect the MD nurse practitioner staffing on any particular day. And the authors did super careful analyses, and they made arguments that their instrumental variables was sound. So I've communicated with many experts. The study can only succeed if the instrumental variable is uncorrelated with everything else. And I'm not sure they convinced me, because it seems to me nurse practitioner and MD staffing would not be truly random. I really need to better understand this paper. I'll link to it. Econ papers read differently than medical papers, but my guess is that if you really get deep into this, you will learn a lot. Now, the issue of nurse practitioner care has immense impact on medical education, right? Think about it. The study suggests that nurse practitioner in an ED setting does not compare favorably to MDs on an economic basis, even given the lower salaries. But if in other settings the performances are similar, as many studies have suggested that I've cited in my 2 previous columns, then the question becomes, why do doctors need 10 times more hours in training? And why does there need to be such restriction into the guild of who can practice medicine? The number of nurse practitioners is now about 1/3 the number of MDs. The need for healthcare is outstripping the supply of doctors, so there is clearly a need to have more empirical data in this area. Okay, final topic today. This is a bad one. Can left atrial appendage closure really reduce mortality? The prominent journal Circulation has published a comparative effectiveness study of older patients with AFib who were treated with either oral anticoagulation or left atrial appendage occlusion, and they broke it down by sex. Now, comparative effectiveness is a buzzword for non-random comparisons. Here, they used Medicare claims data from 2015 to 2019 of left atrial appendage eligible patients. One group of patients were treated with oral anticoagulants. The other group were treated with left atrial appendage occlusion. And of course, clinicians made these decisions, not randomization, so they needed to use statistical techniques to match these non-random patients. And in this case, they used propensity matching. Now, the outcomes they were interested in were mortality, stroke, and bleeding. They matched about 4,000 women and 5,000 men, 1-to-1 oral anticoagulation versus appendage occlusion. And here we go. Sit down for this. Anticoagulation did better. No, just kidding. Do you think this would get into circulation if that were true? No, here are the real results. In men and women, left atrial appendage occlusion associated with a 50% reduction in death. 50%. In men and women, left atrial appendage occlusion was associated with a 35% reduction in stroke, so not as much. Bleeding risk was higher after the device, but lower if you exclude the 6 weeks after the procedure. But total bleeding, which you find in the supplement, was no different in females and actually higher in the left atrial appendage arm in males. The Kaplan-Meier curve that the journal tweeted out was of mortality, and the separation of the curves started in 6 months and was robust at 12 months. The analysis was funded by an investigator-initiated grant from Boston Scientific. Now, I want to read you the conclusions, which resides in Circulation, one of our most prominent journals. Quote, in a real-world population of older Medicare beneficiaries with AF, compared with anticoagulation, left atrial appendage occlusion was associated with a reduction in the risk of death, stroke, and long-term bleeding among women and men. These findings should be incorporated into shared decision-making with patients considering strategies for reduction in AFib-related stroke. My comments. Wow. I don't know how to feel about this other than to be terribly sad for the scientific enterprise. I mean, you would think we'd be making progress, not regressing. The problem here is that the Kaplan-Meier curve that the journal credulously tweets out undermines the entire paper. And I know that the authors know this. I know that the journal editors know this. I don't know what the peer reviewers know, but that too is scary. My friends, even if you believe left atrial appendage occlusion provided some benefit in stroke and bleeding reduction it would be over years, plugging an appendage would be unlikely to ever reduce mortality, but surely not in the first year. What's more, the stroke reduction in the paper was only 35%, and how can that lead to a 50% reduction in death? It can't. If you posit a procedure reduces death by 50%, you'd want a 100% reduction of stroke, and even then that wouldn't be enough. And in this study, there were no differences in bleeding in females, and it was higher in the appendage arm in males, so you can't even use bleeding. And it's not just me making this up. Take the LAOS 3 trial. This was a real trial with real randomization. Surgical left atrial appendage closure substantially reduced stroke rates compared to no closure, but that had no effect on mortality. Why didn't it affect mortality? Because stroke is such a small contributor to death. It's great to reduce stroke. That's a good endpoint. But reducing stroke will not reduce death. So the teaching point here is that whenever you see an observational study with implausible early separation of Kaplan-Meier mortality curves, you know that healthier patients were in one group, here the left atrial appendage group. And what follows, what I'm going to say is not personal, and I apologize, and I know it won't increase my invitations to meetings, but the conclusion that this kind of data should be incorporated into shared decision-making with patients is perhaps the worst thing I have read this year. This data is obviously biased and implausible. The study should not have been done, nor should have been published. The only way this should be published is an example of what biased observational data looks like. That would be useful to show everybody. Oh my gosh, maybe I'm too harsh, maybe I'm too emotional. If you think so, please let me know. If you can find anything positive from this paper or its conclusions, please let me know. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, my friends, if you like this podcast, please take the time to give us a rating, write us a brief review. Even a sentence or two goes a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.